Hello, my name is Dr. Sophie Hose. I am a chiropractic neurologist here at Georgia Chiropractic Neurology Center, and today we will be talking about tremors. This is me. I am a doctor of chiropractic. I graduated from Life University, and I also earned a master's degree from Life University in sports health science with a focus in sports chiropractic. I am a diplomate of the American Chiropractic Neurology Board, and I also am a certified chiropractic sports practitioner with the American Chiropractic Board of Sports Practitioners. This is our team. In the middle you can see Dr. Mark Ellis. He is the clinic director here, and then we have 6 other doctors on staff. There's myself all the way on the left, and then Dr. Jimenez, Dr. Bouth, Dr. Owens, Dr. Wright, and Dr. Patterson. We all work together as a team. We all have slightly different specialties within the field of chiropractic neurology, but we will be taking care of you and your loved ones as a team to make sure that you get better as quickly as possible. Tremors. So the definition of a tremor is just an involuntary rhythmic muscle contraction and relaxation that's causing shaking or trembling, so involuntary movements of one body part or multiple. And different body parts can be involved depending on where the tremor is stemming from. And there's a variety of different causes for tremors, and we'll be discussing a few of them. But when it comes to tremors and how to categorize them, there's a few questions that you got to ask yourself, because not every single tremor is the same as the others. So first of all, you always want to know, is the tremor constantly there, or is it kind of coming and going? So is it certain times of the day? Is it certain environments, or is it certain maybe movements or postures that make the tremor come out or make it stronger or even make it better? Then that kind of ties into the next one, which is going to be, is it a resting tremor or what we call an action or postural tremor? Okay, so resting tremor meaning when the person is not moving, like if I'm standing here and other than my mouth, I'm not really moving, am I trembling or not? Or does it come out when I'm doing a certain movement, or does it come out when I hold a certain posture? So those would be your action and postural tremors, and we go into that categorization a little bit further in just a second. Then we want to know, is the tremor the main problem, or is it caused by something, is it secondary to a certain disease? Like for example, if somebody has Parkinson's disease, they may or may not experience a tremor, but if they do, the tremor would be secondary to the Parkinson's and to the death of those dopamine producing cells in an area of the brain called the midbrain, which is the primary cause of Parkinson's. And that can lead to a tremor. So the tremor itself is, quote unquote, just a symptom of Parkinson's. It's not the main disorder. Whereas, for example, in essential tremor, which we'll talk about in a second as well, the tremor itself is the main disorder. And then lastly, we want to look at the frequency and amplitude, which is more of a clinical assessment, not necessarily something that you would be doing at home. But as a clinician, we always look at basically how often this oscillation, this rhythmic contraction and relaxation is occurring per minute. We call that the frequency. And then how big is the movement? So let's say there's a tremor in the hand. Is it moving like this or like this? Okay, so this would be a bigger amplitude than this. All right, resting versus action tremors. So the resting tremor is kind of self-explanatory. There's not really that much of a grouping underneath it. So if somebody's at rest, they're just sitting or laying or standing somewhere, is there a body part that is shaking or trembling? Yes or no? If yes, we would call that a resting tremor. A good example for that, for example, is Parkinson's disease, where the patient will often have a pill rolling tremor, as we call it, where their hand kind of moves back and forth at rest usually, and it gets better when they move, and we would therefore call that a resting tremor. The other classification is an action tremor. And action tremors can be subdivided into different categories, 3 specifically. We got isometric tremors, postural tremors, and kinetic tremors. An isometric tremor is a tremor that occurs when there's what's called an isometric contraction. So we're contracting a muscle without moving a limb. So let's say, for example, I'm holding my arm here and contracting my biceps isometrically because the arm itself is not moving. I'm just holding a certain position. And if that would cause shaking and trembling, we would call that an isometric tremor. A kinetic tremor is a tremor that comes on with movement, and there's 3 different kinds. A simple kinetic tremor is a tremor that comes on with basically any kind of movement of a certain limb. So if I have a tremor in my hand, if it's a simple kinetic tremor, it would come on whenever I move my hand, okay? A task-specific kinetic tremor, on the other hand, only comes on with specific movements of this body part. So if it's my hand, it might be fine moving it into what we call flexion or bending the wrist, but it might cause a tremor when I'm extending or straightening out my wrist. Okay, so that would be a task-specific kinetic tremor. It's happening with movement, but only with certain movements. And then lastly, for the kinetic tremors, we have our intention tremors, which we usually see with cerebellar disorders, and we'll get to that in a second as well. But they're usually what we call end-range tremors. So whenever I'm doing a movement with a body part, let's say my hand, and I'm getting close to the target of the movement, let's say I'm reaching for my bottle right here. If I'm getting closer to it, and if I'm moving my hand with a certain intention of grabbing this bottle, that's when the tremor comes on. So, and again, it's usually worse when we get closer to it or in the end range. So it would look like this. The movement might be fine, and then it starts to shake, and then if I'm getting close to the bottle, it shakes more and more. So we will call that an end range intention tremor, okay? Lastly, we got our postural tremors, and there's 2 different kinds there as well. We got the position-dependent postural tremor and a position-independent postural tremor, okay? So for the postural tremors, if it's position-dependent, it's a certain posture that elicits a tremor, okay? And it's only that posture. That's not necessarily movement, but there's muscles that are activating to hold this posture, and that's what elicits the tremor. For the position-independent postural tremors, it's basically holding any kind of posture that will elicit this tremor, okay? So this little diagram right here, together with the other classification factors that we just talked about on the other slide, will be diagnostic to some degree for a lot of these tremors. So of course, in our history, we want to consider a family history and history of potential toxicity or injury or whatever other pathology the patient might have gone through before this tremor started. But assessing when the tremor comes on and then when it's there, what it looks like, so frequency and amplitude, is going to be very helpful when it comes to diagnosing a tremor. In the US alone, tremors affect millions of people. The 2 most common ones that we see are essential tremors and Parkinsonian tremors, with essential tremors affecting about 10 million people estimated, and Parkinsonian tremors being a little less common but still very much there. So Parkinson's disease itself affects about 1 million people in the US, which interestingly enough, only about half of people that were diagnosed with Parkinson's disease are actually experiencing a tremor. And that's partially due to the fact that Parkinson's or Parkinsonian disorders in general are progressive. So some people might be diagnosed with it, but they have not yet started to experience a tremor or to express a tremor, which doesn't mean that they will never get it, but they might just not have it yet. So we see tremors in general are an important thing to treat in the US and worldwide as well. It affects a lot of people and has significant effects on people's lives. More specifically, usually fine motor skills are the ones that are most effective for people. A lot of tremors affect the hands. There's other body parts as well, and we'll talk about that in a second, but it's probably the most debilitating if it's the hands or the head that is affected, because it's going to make everyday tasks very difficult, whether it's brushing your teeth or grabbing a pen and writing something down, using a phone, grooming yourself. If your hands or your head are affected, all those tasks are going to be very difficult. So fine motor skills, even just buttoning your shirt, can become a burden or just a very difficult thing to do, and might require that the person has somebody else taking care of them because they can't do it themselves anymore, especially if they're dealing with a progressive tremor that might just be getting worse over the years. Then, of course, activities of daily living, so grooming yourself, brushing your teeth, getting dressed, cooking, just whatever you have going on around the house every day, with not even hobbies, but just the things that you need to do to basically sustain your own life. That's what we call activities of daily living. Those will be affected the more strongly the tremor is expressed, the less independent the person will be. And if it's a progressive kind of tremor, like some of these tremors are, then the effect on the person's daily life is going to get more and more every single day and over the years. So next up, we got work. So for a lot of people, that whether that we have a sedentary job where somebody's sitting at a desk and using a keyboard maybe all day long, and they need to be able to use their hands and have a steady vision and can't have their head moved all the time, or where somebody has a hands-on job where they're physically active. In both of those scenarios, a tremor, no matter which body part it is, but especially hands and head, of course, is potentially going to be interrupting their ability to do their job, which can have tremendous impact on their life, especially if they're a little younger, but even up into our higher years in life. A lot of people still work. A lot of people like their job. A lot of people want to work or have to work to support themselves. If they're not going to be able to do that, that's going to have a tremendous impact on their life and needs to be managed if possible. Next up, we got driving, which, especially here in Atlanta, being able to drive is absolutely necessary for anything that you want to do in life, whether it's getting groceries, seeing friends, going to work, or even just taking yourself to a doctor's appointment. If you're not able to drive, you're severely limited in your ability to live your life, whether it's necessities or pleasure. So if somebody has a tremor that prevents them from driving, it will have a massive impact on their life as well. And lastly, these three kind of go together. For social anxiety, a lot of the time people, if the tremor is visible, if it's, in the hands, in the head, in the trunk, maybe the legs, a lot of the time people might be experiencing embarrassment even, or just generalized anxiety because they don't know what the reaction of their environment might be to their condition, because unfortunately nowadays, no matter what medical condition somebody has, there still is a lot of stigma around it. People might not be as trusting to the person with a tremor to perform certain skills, or there might just be discrimination to some extent. And even if neither of those are present, the person themselves most likely will be experiencing some form of social anxiety or embarrassment throughout this journey that they're on, especially if the tremor is progressing and they're aware of it and they're noticing their own capacities going down. So the mental burden that comes with it not only causes this social anxiety, but can lead actually to mental health problems such as depression or anxiety, partially due to the mental load that it has, but also because our brain works in systems. And if one system is affected, let's say the motor system giving you these tremors, chances are, especially in the progressive kinds of tremors, that eventually the other systems, like for example your limbic system, which is your emotional brain, will be affected as well. And this disorder, this disorder in one system can cause dysfunction in another system as well, which will then lead to other symptoms, for example, depression and anxiety. And overall, with everything that we just talked about, all these ways that a person's life is affected, that just severely decreases a person's quality of life. And if anything at all, we want to, of course, get the tremor better, but we want to increase somebody's quality of life. We want you to enjoy your life. We want you to be able to do what you want to do in life, whether that's the bare necessities or your hobbies or just seeing friends. You deserve to live a joyful life and be able to do what you want to do. So getting back to your normal or to your highest quality of life possible is our goal as a team. And we want to work with you to help you get to that point. All right, we are going to discuss 4 different kinds of tremors. There's a variety out there more than these 4, but we picked these 4 because they're probably the most common ones. that we see in here, but also in the US. So as we already talked about essential tremor and Parkinsonian tremor, and said that those two are the most common ones in the US, with essential tremor being the absolute most common one. And essential tremor is one that usually affects the hands and the head, but it can also affect your voice, so your vocal cords, but your trunk and your legs as well. But again, most commonly the hands, and then everything else is kind of a little less common, but still shows up a lot. And interestingly enough, about 70% of all cases of essential tremor have a familial history of essential tremors. So somebody in the family has an essential tremor that makes you that much more likely to develop this tremor. It usually develops later in life, and it is one of the progressive forms. So with care, the question is, does this become preventable? And if not, can it at least be managed and potentially be reduced? So our goal with tremors is always, no matter what the tremor is, to prevent its progression and at least keep you stable where you're at, and ideally get you better, okay? For essential tremor specifically, it's usually bilateral, so it's not just one hand that's affected, but both, or not just one leg, but both. And it's often misdiagnosed as Parkinson's disease, just because Parkinson's disease is also so very common, and probably just more at the forefront for most people. When it comes to thinking about tremors, most people immediately think of Parkinson's disease. However, Parkinsonian tremor looks a little different actually. So it's usually asymmetrical, so it doesn't affect, let's say, both hands or both legs. And it does often affect the hands, but again, usually just one side, while also usually affecting other body parts as well. So for example, the legs, the chin, so you'll see the chin move, or the whole mandible actually, the whole jaw, and other body parts. And then usually with Parkinson's disease, there's other symptoms that come with it. Again, remember, only about 50% of people that were diagnosed with Parkinson's disease are experiencing a tremor, according to the statistics. But we usually see bradykinesia, which is the medical term for slow movement, rigidity, partially due, one causing the other, and then postural instability. And we often see people with this shuffling gait. They have difficulty to initiate walking. And then masked faces, so like a pretty expressionless face, very small writing. Those are pretty much the baseline or the hallmark features of Parkinson's disease. Now, we already talked about that pill rolling tremor, and again, it's a resting tremor, so it usually gets better with movement. And we call it Parkinsonian tremor and not Parkinson's tremor, because it's actually Parkinsonian diseases is an umbrella term for a group of neurological disorders, and Parkinson's disease itself is only accounting for about 10 to 15% of these disorders. The rest is usually caused due to toxicity, mini strokes, there's multiple systems atrophy, supranuclear palsy that can cause it. So there's a large group of disorders that kind of present with similar symptoms. We call those Parkinsonism, sorry, I said that weird. And again, Parkinson's disease only counts for about 10 to 15% of these disorders. So a Parkinsonian tremor can occur with a variety of disorders. Next up, we got our cerebellar tremor. So the cerebellar tremor is one of those intention tremors that we talked about earlier. So if I'm reaching for my bottle, the shaking gets worse and worse. Okay, so it's not there at rest. It's there with movement only, and it's there with movement with intent. So if I'm just moving my arm randomly and kind of mindlessly, it's probably not going to be there. But if I'm reaching for something, it'll show up, and it usually gets worse the closer I get to the target. Again, we call that an end-range tremor. Okay. Cerebellar tremors are usually pretty slow, so they're not like that, but more slow and high amplitude, so pretty big movement, not just small right here. And again, it gets worse when approaching a target, end-range tremor or terminal accentuation. Cerebellar tremors can occur with a variety of different disorders affecting the cerebellum. So what we see in this office most commonly is probably what we just call cerebellar dysfunction. So there's not necessarily an anatomical problem like a stroke or a tumor, which both of those can cause a cerebellar tremor for sure. But we work a lot with concussions or with pretty much unidentified cerebellar dysfunction, which are usually not visible on scans, whether that's MRI or CT. So a lot of the time, a medical neurologist will tell you that they don't know really what's going on with your cerebellum, but there is dysfunction, and that's kind of where we come in. So we don't work with the anatomical issues, we work with the functional problems. The structure is there, it's intact, but it's not doing its job correctly. So that's basically what a functional problem is. And again, for a cerebellar tremor, we can work with that for sure. And with any kind of cerebellar dysfunction, we usually see a plethora of symptoms to some degree, to some extent. That can be a tremor, that can be ataxia, which is uncoordinated movement. It's nystagmus potentially, which is a form of eye movement where there's a slow drift in one direction and the fast catch up towards the other side. And then dysmetria, which is when let's say you're reaching for something, but instead of, I'm reaching for my bottle, I'm either overshooting and knocking the bottle over, or I'm undershooting and not reaching the bottle, and then I have to correct. So it's basically miscalculated movement. And then lastly, we have functional tremors, which don't really follow any patterns. And that's the main problem with functional tremors. So they can affect different body parts. They can stop and come and go. They can switch from one body part to another. They don't follow a pattern when it comes to what accentuates the tremor, what makes it better. We don't really know. So it's hard to treat it, and it's hard to say where exactly it's coming from, or it's hard to determine one specific area that's causing it, because it can have multiple different origins, okay? And that's where our neurological exam comes into place, and then the neuro rehab as well. So we do a very extensive exam here, and we'll talk about that in a second, that has the goal of identifying what is the problem for you specifically, where is your tremor coming from, where are all the other symptoms coming from that you might be experiencing, and how can we rehab that. So the four main areas that we look at when we're looking at tremors are usually your basal ganglia, which are very primitive and deep structures inside your brain that are associated with movement disorders. So there's two kinds of movement disorders: hypokinetic, too little movement, which Parkinson's falls into that category, and hyperkinetic, too much movement, which is something, for example, like Huntington's disease, where there's these super big involuntary movements, which are not tremors, but excessive movement, okay? Then we got our cerebellum, which we just talked about. It lives at the back of your head right here, and we can see it on the picture on the bottom right. And it's basically there to correct and monitor all input and output that the brain is receiving. That includes movement. So it's supposed to help you have coordinated and purposeful movement. And if there is a dysfunction there, we can see these potential cerebellar tremors, which again are very slow, high amplitude tremors. Next up, we got our midbrain, if there's dysfunction there, we can see something that's called a rubral tremor, which we haven't really talked about here. But your midbrain is also highly involved in vertical eye movements, in emotional processing, and in orienting yourself in the world when it comes to sound and light inputs. And we see a lot of connection there with anxiety and anger outbursts. So that is one where we would make the connection with, like, for example, light or sound sensitivity, anxiety, anger outbursts, problem with scrolling on the phone, fatigue, for example, that you get from scrolling on the phone, so vertical eye movements. That would tip us over more towards thinking that maybe the midbrain is involved. And then lastly, we have our frontal lobes, which are pink here on this picture. They're on the left in the front of the brain. And they are the newest, evolutionarily, the newest area of our brains, and also the biggest structure. So our frontal lobes are basically the CEOs of our brain. They're responsible for executive function and all higher cognitive thought. Okay, so the frontal lobes are what let you be a part of society and let you be a human, basically. They control math, they control reasoning, they control basically any kind of planning and structural function. And one big function that they have as well is movement. So all movement is usually originating from the frontal lobes and is controlled there. So if there's a problem with our movement centers, we will have potentially a problem with tremors, because a tremor is an involuntary movement. It should be controlled, but apparently our frontal lobe is not doing its job correctly and inhibiting this excessive movement. So when it comes to treatment, the most common treatment that's probably out there is medication. And there's different kinds of medication depending on what kind of tremor you're having. But generally, when we're looking at essential tremor, which again is the most common kind in the US, medication is actually only effective in about 50% of the cases, which, considering how many people are affected, that leaves us with about 5 million people in the US alone that are not getting any help from medication. So what do we do for people that can't get help from medication? There's other options. There's certain kinds of surgery that you can do with deep brain stimulation, so implanted devices in the brain, and there's potential ablative surgeries and other kinds out there. Those are terrifying interventions into your brain. Those are dangerous procedures that can be very, very helpful, or they can be detrimental. So it's a big risk to take, and should not be the first line of approach for most people. Other than that, we have physical therapy and occupational therapy to kind of help people deal with the tremor. The goal is not necessarily to get rid of the tremor. The goal with these therapies is usually to help you find ways to adapt your life and to make lifestyle changes, which happens to be the last point on this list here. Lifestyle adjustments is a big factor for people that can't be helped with medication or any other therapies. Lifestyle adjustments are usually the last line of approach, as well as assistive devices, whether that be a cane or potentially even a wheelchair if a person can't walk anymore because the tremor in their legs gets so bad. So those are some of the options out there in the medical world. On our end, we do neurological rehab with you. So again, our goal is ideally, of course, to stop the progression of the tremor, but even better to get you not necessarily tremor free, depending on where you're at in your journey, but to improve the tremor for you. Of course, the goal, ideally, in an ideal world, is going to be to get rid of the tremor. If that's not possible, at least we want to stop its progression and maybe make it a little better. But that is going to be a very subjective journey. We can't promise anything before we actually see you, okay? But you see a couple pictures here from our office. That's my colleague, Dr. Owens, on the left and in the middle, working with 2 patients, and then you'll see me on the right. But we do a combination of eye movement therapies. We use cognitive therapies, balance therapies, different sensory motor processing strategies. We use a lot of myofascial work. We use chiropractic adjustments if we feel like there's a need for it, but it's usually not our first line of approach. But what we do in here is never going to be the same for 2 patients, because we don't believe in protocols, and we think that every single brain is different from another and every system will react differently. And even if 2 people experience the same symptoms, we have found in our clinical practice that they will not react the same to the same therapies, and they might not get the same benefit from them. And even if we find something that works for you, we might not be using it during your next visit because your system changes constantly, okay? Our brains go through neuroplastic changes every single day of our lives until the very end of our lives. So up until someone recently, we thought that, or it was believed that our brain kind of stops changing once we hit young adulthood. But actually, there is new synapses being formed and changed every single day until the end of your life. So we use this concept of neuroplasticity in our office to help your brain recover and form new pathways that are more beneficial for you. And we use these different therapy options in here to make these changes. So what does that process actually look like? So for most of our patients, we schedule a complimentary consultation in the beginning. That means you either come into the office, see the facility, meet the team, and lay eyes on everything, or it's a phone call, and it's complimentary no matter what, and you're welcome to do it at any point. And this consultation serves the purpose to figure out if we're the right place for you. Okay, so you get to ask us any question that you might have. We're going to ask you some questions about your medical history. You'll tell us about your symptoms, kind of what happened to you, what's going on right now. And with that information, we determine whether we think we'll be able to help you or whether you would be better off going somewhere else, whether it be for imaging or for other treatments. A lot of the time we have people reaching out to us and they're in a more emergent medical situation. So we send them either to the emergency room or maybe to a medical neurologist to get checked out first. But this consultation has the purpose of figuring out if we're the best place for you. We don't want you to come in and then figure out that maybe we can't help you, which still might happen after some exams, but generally the goal is to filter that out beforehand. If you need other care, if we think that somebody else might be more skilled at helping your specific set of symptoms, then we will tell you that upfront. And then basically any question that you might have, you get to ask. And then from there, we book you for our initial exam, which is an extensive appointment. At the moment, it's taking about 3 hours. We run diagnostic testing. We do a very extensive bedside neurological exam. No invasive testing, no imaging, just functional neurological tests, as well as orthopedic and visceral tests if we feel like we need to based on your history. And then from there, together with you, we set goals for your care. So maybe your goal is to be able to pick up your grandchild or to walk for 30 minutes without being in pain or without having to hold on to the wall. And then, of course, we have goals too based on our exam findings. And then with these goals in mind, we design a care plan for you that is going to be fluid based on how you're presenting every single day for your appointments. But after the exam, basically, you come in on a regular basis for neurological rehabilitation. Here in our office, we do work with home exercises to some extent at some point, but usually not right in the beginning. And then from there on out, we do regular check-ins. We call those re-examinations, where we check in on your progress and see if you're meeting the goals that we set for you and that you set for yourself. Or if we need to adapt our care. And should we need to adapt our care, then we do that on the spot. And the goal is going to be to get you back to your quality of life and get you to enjoying your life and be as independent as possible. So, if you would like to schedule a complimentary consultation with us, shoot us an email, give the office a call. There's a contact form on our website as well, which will be blended in at the bottom of the screen as well. It's Georgia Chiropractic Neurology Center.com or healthybrainnow.com. Both addresses will get you there. There's a contact form that you can submit and it'll go right through to our office. You're welcome to call, to send us an email, and we will get you set up for your consultation with one of our doctors. And then from there, we'll do our very best to get you back to your life. Thank you very much for listening in, and have a great rest of your day.